Yes, we are live now, ma'am. So, good evening, doctors and all the participants. Thank you very much for joining today's session on Abruptio Placentae, and our guest speaker is Dr. Alkarat, madam.
Thank you.
So it's my honor to introduce Madam. Madam did her MBBS, PGDMCH, and Madam is presently associated with Ladies Clinic and Nursing Home Cuttack, and she has a rich experience of more than 10 years in practicing obstetrics and gynecology. And in terms of academic activities, Madam is very much active in All India Radio and many other academic initiatives from different organizations. So thank you very much once again, Madam, for your valuable time and to discuss such a nice and very important topic that is Abruptio Placentae. And over to you for further proceedings. Meanwhile, I request all the participants, those who are joining from the Shield Connect as well as viewing from the YouTube. So please drop your queries in our dedicated chat box so that after the session, we can have a short discussion on this very important topic with Madam. So thank you very much, Madam, once again for your valuable time, and over to you for further questions.
Thank you so much, Suman. So good evening, ladies and gentlemen. Today we are discussing a very important topic, a topic that is dreaded by most of us in the labor room, Abruptio Placentae. At the outset, I would like to thank Shield Pharma for arranging this webinar. So placental abruption is an important cause of maternal hemorrhage, hypovolemia, coagulopathy, increased rates of cesarean section, and even increased rates of morbidity and mortality. It is also associated with increased incidence of preterm births, stillbirths, and long-term neurodevelopmental disability in the offspring. It is defined as a preterm separation of the normally implanted placenta from the uterine wall after the 20th week of gestation until the second stage of labor. If it happens before the 20th week, that is in the first half of pregnancy, it is referred to as threatened abortion. If the abortion includes the entire placenta, it's called as total abruption, or if only a portion of the placenta is separated, then it's called as partial abruption. So here you can see this is the slide anatomy of a normal placenta, where there is nothing between the placenta and the myometrium. This is a very important slide. The first picture shows a normal placenta where there is nothing between the placenta and the myometrium. The second picture shows placental abruption, where you can see retroplacental clot between the myometrium and the placenta. And the third picture is that of placenta previa, where you can see the entire placenta has covered the lower segment and is just above the internal os. The majority of placental abruptions occur before 37 weeks of gestation, and only 12 to 14% occur before 32 weeks of gestation. The incidence ranges from approx like 3 to 10 per 1,000 births. 1/3 of all antepartum bleeding is due to abruptio placentae. If a patient has had one prior episode of abruptio placentae, there is 5 to 17% of chances that she'll have it in the second pregnancy. And if she has had 2 prior episodes, then the abruptio recurrence can go up to 25%. Surprisingly, we are seeing a decreasing trend in the incidence in USA and other Western countries since 2000. Why? Because since tobacco, smoking is considered to be an important risk factor in abruptio, people have become more aware. So smoking has decreased. Maybe that could be the cause. That decreasing trend could be because of that. Coming to etiology, the primary cause is uncertain. No one can say what exactly is the cause of abruptio placentae. However, several conditions are associated, like increase in age and parity, preeclampsia, chronic hypertension, which is very, very important, preterm ruptured membranes, multifetal gestation. The risk factors are high birth order, maternal age, like young girls, if 20 or less than that, or older women more than 35 are at a greater risk. Maternal traumas such as motor vehicle accidents, assaults, and falls. Hypertension, malnutrition, low socioeconomic status, smoking, which is again a very important factor, and drug abuse, rapid loss of amniotic fluid, previous abruption. Like women, this is probably the strongest risk factor. Women who have had an abruption in previous pregnancies are at a greater risk of having an abruption in the current pregnancy. Short umbilical cord, retroplacental fibromyalgia, sudden uterine decompression, torsion of the uterus, elevated second trimester maternal serum alpha fetoprotein, thrombophilia, and prolonged rupture of membranes if it's 24 hours or longer. So preeclampsia, gestational hypertension, and essential hypertension are associated with placental abruption, and the association varies from 10 to 50%. So the mechanism behind this, why is hypertension considered to be a factor, is there is spasm of vessels in the uteroplacental bed, which leads to anoxic endothelial damage. There is rupture of vessels or extravasation, which finally leads to a retroplacental hematoma. Abdominal trauma is a major risk factor for placental abruption. Motor vehicle accidents often cause abdominal trauma. Trauma could also be because of domestic abuse or assault, both of which are underreported. Cigarette smoking increases a patient's overall risk of placental abruption. Why? Because it's known to affect blood circulation through the placenta, which could theoretically affect the early separation of the placenta. In addition to increased risk of abruption caused by tobacco abuse, the perinatal mortality rate of infants born to women who smoke and have an abruption is also increased. So there are 3 types: revealed type, concealed type, and mixed type. In the concealed type, which is 20% and often more severe, this is much more severe because bleeding, the hemorrhage is confined within the cavity, and there may or may not be bleeding. You may or may not see blood coming out from the vaginal bleeding, and the detachment of the placenta may be complete, and complications are often much more severe. But in the revealed type, which is 80%, blood drains through the cervix. There is incomplete placental detachment, and the complications are fewer and less severe. This is what I told. In the first picture, you can see external bleeding. This is less severe, that is the revealed type. And in the second picture, there is no vaginal bleeding. The entire bleeding is between the myometrium and the placenta. It's retroplacental. That is the concealed type, which is much more severe. So pathophysiology, as I said, the exact etiology is not known. It is postulated that it is the end result of long-standing defective placentation, as it is associated with abnormal trophoblastic invasion and remodeling of the spiral arteries. Rupture of maternal decidual vessels leads to dissection of the placental decidual interface. Pathological findings often show indentation of the maternal surface of placenta with retroplacental clots. Abruption results in thrombin production from tissue decidual factors, provoking preterm contractions and labor. This is just a picture table. Placenta abruption initiates hemorrhage into the decidua basalis, leading to hematoma formation. In concealed type, blood accumulates and seeps into the myometrium, leading to a cuvular uterus. Cuvular uterus, also called as uteroplacental apoplexy, was first described in early 1900s by Cuvular. There is extravasation of blood into the uterine musculature and beneath the uterine serosa, and it is demonstrated only at laparotomy. The picture that I have given here is surprisingly, this is a picture of a real, like a patient that we encountered in our hospital a few days back. You can see the uterus is completely black. This is not how a normal uterus looks after postpartum. So this is a cuvular uterus. Complications in the mother is maternal hemorrhage and hypovolemic shock, increased risk of cesarean section, postpartum hemorrhage, renal failure, DIC, complications of massive transfusions, hysterectomy, and even maternal death. In the fetus, the complications are preterm birth, hypoxic brain injury, fetal death, IUGR, neonatal anemia, and increased perinatal mortality. Signs and symptoms: vaginal bleeding, uterine tenderness, back pain, fetal distress, hypertonus, and fetal demise. The diagnosis is mainly clinical. The basis of diagnosis consists of a proper history and physical examination. Three things: external bleeding through the cervical os, uterine or back pain, and fetal distress. This triad should be of very high suspicion that it could be an abruptio. Never do a per vaginum examination until placenta previa and vasa previa are ruled out. Ultrasound has limited value, but for large abruptions, hyperechoic areas are seen underlying placenta. Fetal heart tracings are common in abruptio. Decreased variability, late or variable decelerations, fetal tachycardia or bradycardia. Other causes of bleeding in pregnancy: the differential diagnosis is placenta previa, vasa previa, preterm labor, cervicitis, ectropion, and carcinoma cervix in pregnancy. The most important differential diagnosis is placenta previa. Here we see a picture. I'll just go through it very short. In placenta previa, it is always painless and recurrent. There are recurrent episodes of bleeding. In abruptio, it is painful and continuous, and it could be revealed or concealed. Bleeding could be revealed or concealed. In placenta previa, the blood is always bright red, but in abruptio, it's dark colored. Placenta previa, the general condition and shock, the amount of shock of the patient is proportionate to the visible blood loss, because whatever blood loss is there, it is out. You can see. But in abruptio, the amount of shock is out of proportion in concealed or mixed type, because you never know how much bleeding is there inside. Then in placenta previa, the height of uterus is proportionate to the gestational age. In abruptio placenta, it's disproportionate because it's concealed. The height is more than the gestational age. The feel of the uterus in placenta previa is soft and relaxed, but in abruptio, it's tense, tender, and rigid. Fetal heart rate is present in placenta previa, but may be absent in concealed type of abruptio placentae. Then DIC is rare in placenta previa, but here it is severe. If you do associated history in placenta previa, is very rare. There are rarely any conditions associated with it, but with abruptio, there may be a history of trauma, hypertension, multiple gestations, and polyhydramnios. If you do a ultrasound, you will see in placenta previa, the placenta is in the lower segment, and in abruptio, the placenta is in the upper segment. So going to the next slide. Ultrasound in abruptio placentae is basically, we have to see the skill of the sonographer about the differing ultrasound appearances, how important they are. When a sudden abruption occurs, there may not be enough time for a retroplacental clot to develop. The variety of appearances include retroplacental clot, preplacental hematoma, subchorionic hematoma, intraplacental hematoma, and intraamniotic hematoma. Abruption may be seen as a thickened heterogeneous placenta that jiggles with gentle bouncing movements that can be felt on the transducer, in fact, the so-called jello sign. Tests that we need to do is a complete blood cell count, blood typing and screening, urine analysis, liver function tests, renal function tests, coagulation studies, all of the coagulation studies like prothrombin time, APTT, fibrinogen levels, and fibrin degradation products. So the classification, there are four grades. Grade 0 is asymptomatic. It's just an incidental finding of retroplacental clot. it's in a regular or a routine ultrasound. Then comes grade 1, where vaginal bleeding is there. There are no maternal or fetal compromise and uterine tenderness is present. Grade 2, there is fetal distress. There is no evidence of maternal shock, but vaginal bleeding may not be present. Grade 3, maternal shock and fetal demise is present. There is marked uterine tetany and tenderness, and vaginal bleeding may not be present. This is the most important and most complicated grade. Treatment modalities, expectant management of pregnancy, definitive management, either you do induced labor, augment labor, or a cesarean section. Management depends on the condition of mother and gestational age of the fetus. There is no hard and fast rule. It all depends on the general condition of the patient and varies from case to case. First of all, you have to stabilize the patient and order immediately for blood, call for help. Never hesitate for calling for help, because always you might need a senior or another person's help in these cases. Large bore IV access, preferably 2 wide bore IV catheters. Fluid resuscitation, preferably with crystalloids. Foley's catheter for urine output monitoring. Maternal vitals, close monitoring, and continuous fetal heart rate monitoring. When there is evidence of coagulopathy, blood product replacement promptly. Okay, so here we'll go a little slow. We'll go case by case. First, we go to term gestation. If it's a term gestation and the patient is hemodynamically stable, we'll plan for vaginal delivery, but with a cesarean section in mind for usual indications. Follow serial hematocrit and coagulation studies. Continuous fetal monitoring has to be done. Any abdominal heart rate where survival of the fetus is expected and cesarean is indicated. If vaginal delivery is imminent, vacuum or forceps can be used. Otherwise, a cesarean has to be done. In the second scenario, where there is a term gestation but hemodynamically unstable, aggressive fluid resuscitation has to be done. Transfuse packed RBC, fresh frozen plasma and platelets as needed. Maintain fibrinogen level more than 150 milligram per deciliter and platelets over 60,000. Unless vaginal delivery is imminent, urgent cesarean section has to be done. The third scenario is preterm. So if it's a preterm gestation and patient is hemodynamically stable, in absence of labor, preterm abruptio should be followed with serial ultrasound for fetal growth. Watch for coagulopathy and deliver at 37 weeks. Steroids should be given to promote fetal lung maturity. If maternal instability or fetal distress arises, delivery should be performed. If not, labor can be induced at term. But if it's a preterm gestation and the mother is hemodynamically unstable, delivery should be performed after appropriate resuscitation. Again, here we should decide whether it should be vaginal or a cesarean section. If patient is in labor, then low rupture of membranes and augment labor. Bedside clotting time should be done regularly. Where should you do vaginal delivery? When there is limited placental abruption, when there is reassuring fetal heart rate sound, when there are facilities of continuous fetal heart rate sound monitoring, if the prospect of vaginal delivery is soon, placental abruption with a dead fetus, there is absolutely no indication of a cesarean section. However, a low threshold for cesarean section should be there, and OT with anesthesia facilities readily available. If an abruption is incidentally found on routine ultrasound in asymptomatic women, the management depends on gestation age and fetal status. In extremely preterm gestation, expectant management, however, vigilance is important and quick delivery is warranted should sudden deterioration occurs. Is there a role of tocolysis in abruptio placentae? Traditionally, tocolytics were not used in abruptio placentae, but abruption is often associated with painful contractions, which can lead to further placental separation and increased bleeding. This leads to even more contractions and there occurs a vicious cycle. Here, tocolysis can stop the contractions, thus breaking the cycle. Magnesium sulfate or nifedipine can be tried in these cases, though not together. In preterm babies, magnesium sulfate can also be used as a neuroprotective. However, it has been postulated by some that tocolysis is controversial and recommended only to patients who are hemodynamically stable and in preterm fetus that may benefit by delaying delivery. Coagulopathy is a leading cause of severe maternal morbidity in placental abruption, and it often occurs rapidly. In cases of abruption, treatment for DIC must be started immediately. But how do you know that DIC has started occurring? Blood must be placed in a plain red top tube with no anticoagulant. If it doesn't clot within 6 to 8 minutes, a diagnosis of DIC can be made and the patient will require blood transfusions and other products like platelets and fresh frozen plasma. An important part of treating DIC is removing the cause, that is the placenta. That is done either by vaginal delivery or cesarean section depending on the situation. All cases of abruption resulting in fetal death must be assumed to have coagulopathy. Platelet transfusion must be considered when platelet count is below 25,000 per cubic millimeter. General management, first is delivery. You have to resuscitate the patient with fresh frozen plasma, whole blood and IV fluids. BP has to be monitored and vitals have to be monitored continuously. Catheterization is done to monitor urine output. In carefully selected cases of abruption at preterm, like prior to 34 weeks, if both maternal and fetal conditions are stable, with no evidence of coagulopathy or severe hemorrhage, expectant management may be considered. Prior to 34 weeks, in whom decision has been made to prolong pregnancy beyond 34 weeks, steroids should be administered to promote fetal lung maturation. But cases prior to 32 weeks should receive magnesium sulfate as a neuroprotective. In carefully selected asymptomatic cases, this is important. In carefully selected asymptomatic cases where the bleeding has stopped for more than 48 hours, with reassuring fetal and maternal status and reassuring fetal heart rate tracings and ultrasound, outpatient management may be considered, with the patient being counseled about all the major risks to the mother and the baby. Next comes cesarean section. Indications are if it's a salvageable baby, if there is severe vaginal bleeding, if there is poor progress, and if there are malpresentations and an inadequate pelvis. But post-delivery, you have to watch out for PPH because myometrial myofibrin loses contractility and there is failure to clot. How do you prevent? Prevention of known factors, early detection and effective therapy. If you're doing a needle puncture, like if you're doing an amniocentesis or anything, it should be ultrasound guided. Avoidance of any kind of trauma. Avoid sudden decompression of the uterus. Avoid supine hypertension and routine administration of folic acid. So this is just a chart of what we discussed, like term, preterm, how to manage. So to summarize, abruptio placentae is an important cause of fetal and maternal mortality and morbidity. The etiology is poorly understood. Various management options are, however, available. The principle of initial assessment of the patient's condition and subsequent planned management aimed at resuscitation and prolongation of pregnancy if possible, or immediate delivery either for fetal or maternal conditions. However, each case is decided on its own merit, and there is no hard and fast rule for every patient. The management varies from patient to patient, depending on the hemodynamically stable or unstable patient, and there is no fixed treatment for abruptio placentae. Thank you.
Thank you very much, ma'am, for this nice presentation. Just give me 1 minute time, ma'am.
Should I stop sharing and go to the main screen?
So, ma'am, the first one question is how to assess the severity of the vaginal bleeding.
How to?
Madam, am I audible?
Yeah, you are audible. Yeah. How to?
How to assess the severity of the vaginal bleeding in case of this abruptio placentae.
It's revealed kind of abruptio placentae, you can definitely see how much bleeding has been. It will be visible. And in concealed type, there'll be very less bleeding, but the patient will be in shock. So you can obviously decide that if the patient is in shock and there is very less bleeding that is visible, so that can show. And in this case, if you do an ultrasound, it will definitely show the amount of bleeding, retroplacental clot, and the size of the uterus also, because if it's concealed type, the gestational age will not match with the size of the height of the uterus. It will be more than the height of the uterus. From there, you can assess the amount of vaginal bleeding.
And what is the greatest risk factor of this abruptio placentae, and what is the prognosis?
The greatest risk factor, I would say, is maternal hemorrhage, and hypertension is a very big factor, because in hypertension there is hypertension. Let me continue. In hypertension, there is there is spasm of the vessels in the uteroplacental bed, leading to anoxic endothelial damage, and ultimately there is rupture of vessels. So there is a formation of a retroplacental hematoma. And if there is a past history, like if she has had a previous pregnancy, if she's had a abruptio, there is a, I told you, there is a 5 to 17% chance if she's had one abruptio, and there is a 25% chance if she's had two abruptios. That is the strongest risk factor, previous history.
And is the prognosis, ma'am?
Prognosis depends on how fast you work, actually. If, like, the doctor has to be very vigilant, monitoring has to be done continuously, and if the baby is salvageable, do a cesarean section, or immediately arrange for blood. And if you have an OT with good anesthesia facilities, and if you can save the baby, then immediately go for a cesarean section. Unless vaginal delivery is imminent, then you can have a good, even the baby is safe and the mother is safe.
Thank you very much, ma'am. And one last question is, yes. So one last question is, during your diagnosis of this abruptio placentae, so what are the other parameters need to keep in mind to conclude or to say further procedures or something? So what is your opinion or thought in your practical approach or in your practice?
I didn't get the question. Could you repeat, please?
Yeah, ma'am, in case of your suspected case of abruptio placentae, so what are the procedures you need to check in your practical practice?
What are the procedures?
Yes, procedures mean in investigation, you can say rather.
Obviously, you have to do a complete blood cell count. You have to do you have to monitor urine output. all the renal function tests, the liver function tests. You have to do coagulopathy studies. You have to do like all the tests have to be done to see if the patient is hemodynamically stable or not.
Thank you. Thank you. Thank you very much, ma'am. So thank you very much, ma'am, for this nice session on this abruptio placentae, which is a very important topic, and to discuss a few queries as well. So thank you very much for this nice session, and in future also we will be look forward for some valuable session with you. So thank you very much, madam, once again for your valuable time on our platform Shield Connect. Have a good day.